Perimenopause, the transitional period before menopause, marks a pivotal time in a woman's life where hormonal fluctuations can lead to a wide range of symptoms and changes. It's a journey that approximately 1.3 million women in the United States enter each year, yet the path is far from uniform. For many, this transition brings about challenges not only in personal health and well-being, but in finding the right support and treatment. The complexity of perimenopause lies in its variability. The symptoms of perimenopause can begin as early as the mid-30s and last anywhere from a few months to over a decade. This variability poses a challenge not only for the patients, who often feel misunderstood and dismissed, but also for practitioners striving to provide the best care. Diagnosis and treatment are complicated by the fact that every woman's experience of perimenopause is unique, and what works for one may not work for everyone. Now, amidst this complexity, our guest today, Dr. Angela DeRosa, stands out as a beacon of knowledge and empowerment. With over 25 years in the medical field, Dr. DeRosa has dedicated her career to enhancing the understanding of hormonal health, advocating for an integrative approach that combines the best of conventional and alternative care. Founder of the Hormonal Health Institute, Dr. DeRosa is passionate about empowering women and men to navigate hormonal changes with grace and knowledge. Today, Dr. DeRosa will help us unravel the mysteries of perimenopause, shedding light on the signs, symptoms, and the importance of a personalized, integrative approach to care. Step on the back. Thanks. Get a little lower, please. We'll delve into the challenges in diagnosis and treatment and explore how women can advocate for their health during the transitional time. This transitional time. So whether you're navigating perimenopause yourself, supporting a loved one, or simply eager to learn more about women's health, you're in the right place. Let's get started. How's that?
Shazam.
Not bad.
Shazam.
Not bad.
Not bad.
All right.
Your voice for radio.
I got my little I'm ready with a list of questions because this is important. I don't want to miss anything. All right.
All right.
So, Dr. DeRosa, welcome to the show. Before we get started,
yes.
How do you want me to address you? Should I say Angela, Dr. DeRosa?
Dominatrix of
Dr.
healthcare.
Angela DeRosa. D.O. MBA. I want all the titles. All the titles.
Dominatrix of healthcare.
Welcome to the show. I am honored. It's a privilege to have you
Thank
here. I'm very excited about this. Even when I first read about you, heard about you, like, I got to get on the podcast. I didn't have a podcast back then. But when I get a podcast, she's going to be on it, right? So talk to us about your background. How did you get from getting out of med school into being the queen bee of hormones?
The queen bee. I thought that was Beyonce, but I'll take the title.
I mean, hey, don't let the beehive come after me now.
No, we don't want that. But it was actually a collision of a professional and personal crisis. So I was in the medical school in my residency training when I really started to notice at first not some subtle kind of symptoms, but then it became very overt. I was starting to not sleep well, I was having hot flashes and night sweats, and I was also starting to notice I was getting depressed and anxious, and I'm actually a really happy person. I was starting to gain weight even though I was barely eating and very, very active, as you can imagine, as a medical school and resident. But the most alarming thing that started happening is I was having syncope, so I was passing out when I was exercising. And my first stop was to a cardiologist, and I did all the stress testing, the echocardiograms, and all this, it was $1 billion workup. And they basically said, you know what, you're probably just stressed, go on your merry way. They put me on a beta blocker, which slows your heart, slows your metabolism, and they really equated it to stress. And it wasn't until many years later that I realized I was 35 years old, and all of a sudden I was in overt full-blown menopause. And what was actually happening to me was perimenopause. I was having all the symptoms of estrogen deficiency, testosterone deficiency, and a lot of women, actually surprisingly, when they move into the perimenopause and menopausal transition, estrogen deficiency causes heart palpitations, heart arrhythmias, and in some severe cases, like in mine, because I went through menopause so early, I was passing out when my heart rate got too fast. And it wasn't until I realized that was really what was happening to me, and I was really angry when I figured it out and how poorly I was treated, because at the time, in my medical school training and my residency, I saw cardiologists, endocrinologists, all the ologists you could possibly imagine, and I was completely dismissed, patted on the head. So there, sweetheart, reduce your stress, go on a date night with your husband. I was newly married, and try to get some sleep even though I was in residency. But I was in full-blown perimenopause, and I was dismissed. So I vowed at that time, when I figured out what was happening to me, that I was going to do everything in my power to never allow another patient in my care to go through that experience. And I wanted to learn everything I could about hormones, and not only how they affect us symptomatically, but I'm an internal medicine trained physician. I wanted to better understand the chronic disease state prevention that is so missed, because we put medications on symptoms of menopause and perimenopause without even addressing the root cause of the hormone deficiencies. So it's been a passion and a mission my whole entire career.
Now, one thing we mentioned, the Hormonal Health Institute, which is a training platform you started.
Right.
So, now your journey has gone through. You figured out what's going on with you. You want to help other people. You start your practice. You want to all that, multiple practices, if I'm not mistaken, right? And now you're at this point where it's the next phase for you, right? So how did you get involved with founding the HHH? See, I told you.
I know, HHI.
Say that 5 times.
HHI. Hormonal Health Institute.
I got it.
So we got to get you doing like a cheer.
I will do that.
So my career, actually, a lot of people think it's been kind of serendipitous, but it's been very, very purposeful. I was lucky enough right out of my residency to be asked to be one of the new medical directors for Procter & Gamble when they first launched into pharmaceuticals, to help them develop an osteoporosis drug as well as a female sexual function drug. I took that opportunity and left my clinical career to go learn everything I could about all this from international experts. But I knew that was going to be a limited time frame. I wanted to learn from the best on marketing, brand equity. How do we get drugs through the FDA? But more importantly, who are the smartest people in this field? And I wanted to learn everything I could from them. But I knew that eventually, after about 10 years, I was going to want to get back into clinical practice, take all of that learning and then apply it and build the foundation. I needed to go do what I was learning so that I could be deemed someone who was credible in this field. So I spent the next 15 years after that building a practice. We got to 7 locations. I've treated tens of thousands of patients. But I knew that I can only affect change one-on-one when I'm treating patients. And although that's a wonderful thing to do, in order for us to change the paradigm, I've got to train other people to do what I do. So I build the foundation with the practice. I've trained even hundreds of people that worked for me, but then I knew I needed to parlay it into getting doctors, physician's assistants, PAs, NMDs, all of those folks to do what I do and do it well, because there's a huge misunderstanding about hormones in medicine, but also there's not enough of us that really know what we're doing to do this and do it well.
So speaking of misunderstanding, that's the topic of the day right here, because perimenopause is complex. It's hard, and this is just, even as a physician, it's just like, it's so hard to be like, because it's more of a retroactive thing, right? It's just like,
unless you can recognize it.
Right, exactly.
Yeah.
But in most cases, it's like, oh yeah, you were there a while back. Mm-hmm. But to understand all that, let's start from the beginning. What is perimenopause? So
peri means around in Latin. So it's around the time of menopause. And the way I look at it, it's the time leading up to menopause. So the ovaries are really tiny, sensitive little organs, and one day they're going to decide to retire. Genetically, we are programmed to have our ovaries fail at a certain age unless there's some kind of trauma that occurs ahead of that, say like chemotherapies, you have surgery, obviously taking them out, that's going to do significant damage. But let's say you are scheduled, programmed genetically to go through menopause at 50. The ovaries, like people, we don't just decide, okay, I'm going to retire, and we retire tomorrow. We have a slow lead up typically to that. And the ovaries usually slow down about 10 to 15 years ahead of full menopause. So we normally in our mid-30s is when hormonal imbalances start, and it's usually testosterone deficiency, which we don't recognize in women. But it starts insidiously in the 30s, and then the 40s it becomes more dramatic, and then boom, Elvis has left the building, and it certainly started. But a lot of the symptoms that we have in our late 30s, early 40s, we get dismissed as being depressed, having fibromyalgia, or that we're crazy. So the same symptoms that a woman would walk into in a doctor's office that a man would, they're both testosterone deficiency. So fatigue, mood disorders, cognitive delays, low libido, lack of orgasm strength. If a man walked into a clinician's office, they're going to get either an erectile dysfunction drug plus probably testosterone. A woman presents the same exact scenario. We get thrown on antidepressants when we actually need testosterone. So we are snowing all these women when we're not even recognizing the syndromes of the hormonal imbalances that are starting to occur. But it takes 10 to 15 years. That perimenopause is 10 to 15 years. And our lives start to change, and it's so insidious sometimes that we think that that's all there is.
And that's interesting, right? Because, and I think as a doc, you may miss that because, again, you come up with the symptoms here. But even through perimenopause, as you know, testosterone has cyclical throughout the month, right? And so depending on the timing of the labs, it's like, wait a minute, you're here, your testosterone should be a little lower right here. So how's that doc who can be kind of smart, semi-smart, relatively intelligent, right? Besides looking at the symptom picture, because you got the symptoms, you're still going to look at the labs, right?
Right, but the problem is with the labs is that a lot of clinicians have no clue. Even the smartest of smart people I know have zero clue on how to properly interpret hormonal labs because they have these quote-unquote reference ranges, and if they don't fall within them, then they dismiss what could potentially be a problem. So the reference ranges for women are inadequate completely for testosterone in women. But also, if you don't know how to interpret the cyclic variation, you could misdiagnose somebody. So at certain points in your cycle, for instance, progesterone is supposed to be very, very low, the time leading up to mid-cycle ovulation. But that time from ovulation to, say, when they start their menses or the bleed off, that time progesterone is really high. But if the blood work's drawn in the first half of the cycle, it's going to be low, and the doctors go, oh my God, you have low progesterone, and the next thing you know, they're on progesterone, and they feel like crap.
Oh my God, the cycles are a week apart. What are you doing?
Right, so it's inherent. It's really important for the clinicians to get the proper training to properly interpret the labs, because if they're just doing a snapshot in time and they don't know how to interpret it, they're going to misdiagnose the women, and they're likely going to misdiagnose, or they're going to mistreat them and treat them with things that they don't need at the wrong time.
So you mentioned the testosterone part, because that's a shift. Right? And so is it more of a domino effect where it's like, hey, I know it varies, right? The whole thing is different with everyone, right? And so, but is it a domino effect where it's like, hey, testosterone the first to fall, and then progesterone, then maybe estrogen, right? Do you see that, or is it kind of depends on a lot of different factors?
Unless you yank the ovaries out when you have a decline in all of them immediately, I have seen a certain progression. Testosterone always falls first in women. Because when I look at it, testosterone is, although it's very, very important, put a gun to my head, I'm going to take testosterone and replace it in me and my women, hands down over estradiol, because it does so much for us. But it's so dismissed and misunderstood. But it is always the first to fall because we don't store it anywhere. Estrogen is very savvy. So estradiol in particular, it stores in our fat cell for a rainy day. So it's like a savings account where testosterone is just cash. So as our ovary starts to slow down, testosterone is the first to go. So if a woman walks into my practice with a hot flash, she is already testosterone deficient. She has to be. And then you start to see the slow progression of the estradiol deficiency, which leads to the hot flashes, night sweats, and all those things. And then when the periods become irregular, we know that progesterone is really getting out of whack too. So it typically goes testosterone, estradiol, progesterone, where a lot of folks think that it's progesterone followed by estradiol, and they don't even mention testosterone in women. And it's one of our most important hormones. We actually make more testosterone on a day-to-day basis than we do estradiol. And we don't even talk about it in women.
I know, I say that all the time. Not all the time. Maybe once a quarter.
once a quarter.
I'm like,
we should say it every day.
Yeah, no, it's testosterone you make. It's super important, right?
And it does the same things for us. But here's the problem. If women present with testosterone deficiency, we get the antidepressants. Men get testosterone. There is a huge gender bias in medicine.
Except for here.
Except
for
man,
I'm all
you're a very evolved male.
All about it. Like you definitely need this. But I think the problem happens in a lot of cases is when you have that conversation with a patient and they go to their PCP.
Oh.
Again, I'm not here to knock PCPs. Some of them are great, but sometimes it's like they're in such a general bucket. It's like the expectation to know everything about everything, right. But sometimes you just don't. And you have that case and you're like, hey, I see your lab work, I see your symptoms, I really want to put you on testosterone. Oh, great. I go to my primary care, they come back, oh my God, they said you're going to give me a heart attack, and I'm going to grow a beard and a goatee, and all of a sudden you're like, oh, wait, stop.
Time out.
Or they get started and they have their lab work and they take it there and it's like, oh my God, your testosterone's 120.
And they think you're going to turn you into a man.
Exactly.
So but again, it's a lack of education in our medical school training. It's unfortunate because we don't learn the proper training, and actually the rest of the world does a much better job than we do here in the United States. And it's important, and what I've seen actually over the last 30 years I've been doing this, that women advocate for themselves. And it's not the medical profession that's driving this. It's the consumer, the patient, who is driving this because they know something's wrong intuitively with their bodies, but they're saying, oh, your labs are fine, when they're entirely not okay because they don't know how to interpret or look at the labs. But when we talk about testosterone, you're right, because the symptoms are actually somewhat more important to look at than the labs, because the labs are problematic for women. So if a woman's walking in, they have low libido, that's very specific to testosterone deficiency. They have a difficulty orgasming, or their orgasms aren't as great as they used to be. Libido is a huge component of that. But there's so much more. We start to become insulin resistant. We put midsection weight gain when we lose our testosterone, because it's testosterone that moves the blood sugar into the muscle to burn clean. When we lose that, the pancreas has to deal with it. It burns out. We become insulin resistant. We gain weight, and the next thing you know, we're diabetic and having a heart attack. That is testosterone's most important role. It is also Mother Nature's serotonin. So we get anxious and moody and depressed. And again, there's where the antidepressants come in. Or we don't have good muscle endurance or strength. All the same things that men struggle with. But it's recognized in them.
And that's the wild part about it. You see those symptoms and you see the labs, and it's like, why are we not putting two and two together? Because you get it. They come in, it's like, hey, my A1C is high, and my cholesterol is high, and it's just like, you don't need metformin, you need testosterone, right? That's a whole.
We have a whole society of people with insulin resistant that would be treated with just testosterone.
So I was like, it would be just great to have that conversation. Like, why don't we start with this, right? Or I'll say, start with this and maybe stop eating.
Well, it's the root cause drivers, and this is the problem with our current medical society. Yeah. Pharmaceutical companies are making billions and billions of dollars off of keeping us sick. They don't want us on hormones, which is why they're fighting against compounding pharmacies or the folks that do this kind of medicine like we do, because they want to keep people sick. That's how they make their money. Right. There's no investment in preventive medicine because nobody gets rich off of it.
There's no money in the cure, as they say.
Right, and hormones are cheap. They're very cheap, and they're readily available in the right hands.
And I guess, and also I don't want to, I always have that talk, it's like, yes, the hormones are great, but maybe lay off the Oreos.
Well,
you have to,
come on.
You gotta put some work in. You gotta put some work in.
You're no fun,
I'm literally no fun. It's like this, I love my analogies, right? It's like you can have the best grill in the world, right? You can have the best Traeger grill, the best environment, right? And it's just like, but if you don't know how to cook,
that is very true.
Hormones
fix the root causes, but we don't need. It's not going to it's not going to fix really bad
dietary habits. You got to know how to prepare the meal, right?
But
it gives you the fuel.
But if you don't feel good, or if you have testosterone deficiency, you become insulin resistant. You crave sugar more.
Now it's even worse, right?
So it makes it harder to control the things.
So one of the things when I talk to patients about, and I know you mentioned kind of the hormonal cascade, is that men were easy. We're so easy. It's like, oh my God, I could just see. Here's some testosterone. Here's an estrogen blocker if you need it. Here's a little bit of vitamin D. I'll see you in 3 months. Yeah, see the lady at the front, right? But women are different. It's not a 3-piece band. It's a symphony orchestra, right? And it's like, and sometimes the horns are aggressive. And guess what? The bass player didn't show up today. He's not even there today. So how do we work with that? So that being said, let's talk about, because it's not just estrogen, progesterone, testosterone in these cases too. There's other hormones.
Absolutely.
So what is the role of the adrenal glands and even thyroid when it comes to this perimenopausal?
So I call it the axis of evil, first and foremost. The estradiol, testosterone, and thyroid. They are 3 musketeers playing in the sandbox, and they all directly influence one another. If your thyroid is not functioning well, testosterone's not going to work well, and vice versa. So, and I see the decline in thyroid mimic the same perimenopausal transition in women. Almost 90% of the women by the time they're 40 are struggling with some thyroid dysfunction. And it may not meet the criteria of quote unquote hypothyroidism that the Endocrine Society and conventional doctors talk about. But the problem is the conventional folks, they wait till the bus has hit the wall before they even intervene. You're gained 40 pounds, your cholesterols are all messed up, your hair is falling out, you're tired all the time. So why would we do that? Why wouldn't we intervene when things are slowing down? And there's so much in our environment right now that are affecting these little organs, the thyroid being very, very important. So I see thyroid almost hand in hand with almost all of the women I treat these days. It's slowing down and it's causing havoc in our bodies. So it's really important. I call these the big hammers: testosterone, estradiol, progesterone if you're treating with estradiol or needing to regulate cycles. But thyroid, you've got to treat those big hammers. Then once you get, then if you want, let me back up and talk about thyroid. That is where people get incredibly tired, which you couple that with testosterone deficiency. Forget about it. These people are walking zombies. They're losing hair. It's coming out in clumps. You'll see lateral eyebrow thinning. The eyelashes are falling out. They're gaining weight on top of all of that. And they get cold all the time. Their extremities may swell. So there's a whole host of things that pile on to all the other hormone problems. So you've got to fix those before you do anything else. And the reason is they're big drivers. And if you don't have the patient feeling well really quickly, our society today, we want instant gratification. If they don't feel well, they're not going to trust you to do some of the more, I would say in some ways, the gut health, nutrition, adrenal health, those are equally, if not more important, but they don't give you the quick impact. You have to work longer and harder on those. So the adrenals, that's that stress hormone. And you think T-Rex is chasing you all day long and it just never goes away. But given our society today, it's no wonder we're not all like adrenally messed up because our bodies are under chronic stress. And then the gut, as you know, you're a naturopath, and you know more than I do that the gut is so important and how it modulates serotonin and our wellness, but it's the largest part of our immune system. So you have to treat all of them. But I find that patients do better when you start with the big hammers and then gradually work down.
Start feeling better and you build that rapport, that trust, and now it's like you can get through the day. Right? Because if you're so tired and you feel like crap, dude, I'm not trying to hear about your probiotic. Like,
no.
You know what I'm saying? Like, I can't get out of bed right now. Like, you keep that to yourself.
Because that may not feel really well up front, but down the road.
So you kind of mentioned something about, like, just you mentioned earlier about, like, that transitional period here. And I think that, and this may sound like it's almost sometimes these transitions we have where it's like, and then we go through andropause, right? It's not I don't want to call it a disease.
It's not a disease. It's a natural part of aging.
It's going to happen, right?
But we want to trick Mother Nature.
Right, yeah.
Because the way I look at it, so in particular in women, men take a much slower, longer decline to get to andropause, and because they can father babies well into their 70s, which biologically that makes sense. You want to spread the seed, to get as many women as pregnant to keep the genetic pool going. But in women, Mother Nature never intended us to have babies in our 60s and 70s. It would be absurd because, first off, the babies probably, we wouldn't be able to care for them properly, and then we may die before they even reach adulthood. So biologically, the mother is there to take care of the child, or the husband's there, or the father is there to spread as much as he can around the world. But the problem with the ovaries failing at 50, it's designed. Mother Nature doesn't want us to get pregnant. But when we lose those hormones, we start to rapidly age because the ovary not only doesn't make eggs anymore, it doesn't make hormones anymore. And biologically, once we can't have children anymore, Mother Nature is done with us. But unfortunately, as human beings, we now live 30 years, 40 years past the menopause. Our time has changed. And we don't want to just die and go stoically into the night.
There's a lot of female listeners that are going to maybe share this with their husbands, and they're going to cut that part out. That their job is to spread the seed around the world. Because as you said, it was like, is this my job?
No, biologically. I'm not encouraging anybody to do that.
Around the world.
Around the world. Just go spread seed.
Heading overseas now. Heading overseas to do my job. So here's a question where you kind of mentioned that mid-30s. Is that the typical age for starting perimenopause?
Mm-hmm. On average, probably 80 to 90% of women start perimenopause in their mid-30s. And in my case, I was one of those 10% of women that went through what we call premature ovarian failure or premature menopause before the age of 40. And my symptoms, if I was genetically programmed to fail at 35, which meant 20s is when I was going to start to experience it. But the average woman is typically going to be mid-30s, leading up into the 50s when the ovary shuts down.
That's a good point because, honestly, I never think about that. You read it, but he's like, no, you start seeing more of the symptoms a little bit later, but this could be very.
Well, it becomes more overt.
Yeah.
But the problem is too, a lot of nonsensical things get told to women. If you're having regular periods, your hormones are fine, it's insane. So you're too young to have ovarian failure or having hormonal imbalances. I was in my 20s, for God's sakes, and people dismissed it. So it happens. And I always tell women, trust their bodies. If they don't feel right, something's likely not right, and seek answers and go to people that you trust. But if you're not getting the answers you're looking for, keep seeking, because there's folks like yourself and myself out there that are doing this. And the good news is it's getting better. There's more and more of us doing this kind of medicine and recognizing it versus 20 years ago, 25 years ago when I started.
So I want to talk symptoms in our next segment here, but one of the things I kind of want to, just kind of that medical process of like, symptoms, diagnosis, all that. What's the challenge in the actual diagnosis that you see? Like, why is it hard to say, hey, you're coming in, you got some symptoms, not just some symptoms, very overt symptoms, low testosterone, mood issues. Why is there a challenge in the diagnosis? Like,
lack of education on doctors and providers.
Yeah.
Unfortunately, there's not a lot of us well trained in this. And the women out there are getting better now. They're obtaining better knowledge through seeking and researching than we are trained in medical school. Do you know how much menopausal training I had in medical school? None. Or perimenopause. You look at curriculums nowadays. I work at the medical schools, and I even helped develop a curriculum for one of the local medical schools. And the time that you're allotted to be able to deliver that knowledge is very, very minimal. And most clinicians today are really responsible for seeking that education themselves, and where do you find it? And where do you find good quality education? You yourself have been going through different credentialings and fellowships and various things, but there's very limited resources. And you have to be motivated, and you have to know what's BS and what's not. So I think that's the greatest hurdle, is because the patients are demanding this of us. We just don't have enough of us to do it and do it well.
Yeah. Challenge, and then you got to make some mistakes.
It's
a trail off in the distance, right?
No,
speaking from experience, you're like,
when I started going through this, I started learning. I've probably done more damage in the name of science to learn more about hormones to myself, because I wanted to figure out, what's working. I would learn from one clinician, then I would try some things, and that didn't work, so let's try this. And because I've been doing this a long time, and although I had really good mentors, a lot of it came from my own trial and error. And now I can share those experiences with others, so they don't necessarily have to make the same mistakes.
Right, which is a good thing, because it's not easy. So we kind of, I want to say dance around a little bit, we kind of mentioned it. So when it comes to perimenopause, like, what are some of the most common symptoms that you see?
Well, when I break it down for my women, as we keep talking over and over again, the first thing to go is testosterone in women. Presents exactly the same in men. Low libido, lack of orgasmic strength, fatigue, mental clarity issues. It's the executive function thinking. Like, I have to read a paragraph 3-4 times in order to retain the information. We start to gain that midsection weight. We start to see sugar cravings, that insulin resistance, muscles hurt. We go work out. It takes us 4 days to recover. We get depressed, moody, anxious, new onset panic attacks. I mean, we're a hot mess from testosterone deficiency. Then once we move into phase 2, that's the estradiol deficiency. It's the hot flashes, night sweats, the insomnia. We start to see more allergies, because not only does our vagina get dry, so do our nasal passages. We have painful sex because of the dry vagina. We start to get heart palpitations. Women get $1 million workups every year, but heart palpitations, the number one cause is estradiol deficiency. We start to get foggy. So I always say testosterone is kind of the hunter, executive function thinking, that very discrete kind of thought process problems. Estrogen communicates. All of our brain centers start to get foggy because we don't communicate the centers anymore really well. We start to see dry eyes, vision changes. So there's a whole host of things that happen. And then when we get really, really close to menopause, usually a year or two before that, our periods start to become irregular. We may go months in between a period, and then the periods we do have are really heavy, filled with clots. They're very painful. Or you might start to even see patterns where you're having periods all the time. It just depends on how each woman goes. So, it just keeps progressing, and it gets so bad that eventually some women say, this doesn't feel right. But if it's slow enough and insidious enough, some women go, they don't even realize how bad they feel until they feel better. But everyone thinks about menopause as just hot flashes, and it's so much more. We're more than just a hot flash.
I know. Call him
Dr. Hot Flash.
I'll talk about that later. So one thing, when you mentioned the testosterone thing, and I was like, man, I should ask about this earlier, but I want to circle back to that. What's the challenge, and this is another underdiagnosed and kind of misdiagnosed thing, is PCOS. What's the challenge in a female? Because for those who don't know, PCOS, they tend to have higher testosterone.
It's the flip from what we normally do.
Right, exactly. And so they're not independent. So if someone has PCOS and they just never got diagnosed, never got treated, talk with birth control. Oh my God, it's like I was went there.
Birth control.
I was went there. It's like, oh yeah, so it's like, okay, so you're trying to have it.
That's a whole other podcast.
Naturally, right? So now you have this history of PCOS. Now, does that make the diagnosis more difficult?
It can be. PCOS patients are challenging because, well, first and foremost, that a lot of women are inadvertently treating themselves and they don't even know they have PCOS. And what I mean by that is one of the treatments for PCOS. So as you alluded to, PCOS is the flip. We have too many testosterone molecules, too many androgens relative to the estradiol in the system. Those patients get usually infertility, they gain weight, they become high cardiovascular risk, and they almost always have thyroid dysfunction with that pattern. So what usually drives women to be diagnosed with PCOS is they try to get pregnant and they can't. Or they get the facial hair that's extreme or the acne that is extreme and somebody does a workup. But what's interesting about PCOS, what treats PCOS, is you have to shut the ovary down from overproducing all these androgens. So what does that? Well, menopause does. Mother Nature cures it because it shuts the ovary down. But another way to do it is put people on birth control pills. So if women are starting birth control pills for contraceptive needs or irregular periods in their, let's say, teens or early 20s, they're treating their PCOS. And inadvertently, but then when they decide, oh, I'm going to get pregnant now that I'm 30 years old, they stop their birth control period, and then all of a sudden they can't get pregnant, and then all of a sudden they get diagnosed. So women are self-treating without even knowing they have PCOS a lot of the times. But as I mentioned, the heralding symptoms are the excessive hair growth, the irregular periods, infertility, acne, weight gain. I mean, and it's a problem because these patients are at really high risk of insulin resistance and cardiovascular disease. But the interesting thing is as they move through the perimenopause, the PCOS starts to get better because the ovary's slowing down. And the hard part with these patients is because even though they have too much androgen, at some point it may get too low and they need to have some back, which is counterintuitive. And this is a very complex topic for even most clinicians. Right. But it's a challenging patient to deal with, and you really need to have someone who's specialized and understand it to manage it, because I've seen a lot of patients get really screwed up by improper management.
So, great segue, Dr. DeRosa. So, speaking of management, so let's talk about managing perimenopause, right? Because obviously, what's great about this is you coming from the conventional world and transitioning to the functional world, and here I am with the naturopathic world here. So we got all the bases covered here. So is there a difference in the conventional treatment of perimenopause versus is
That's
there
a loaded
even
question.
any treatment? Is there even any treatment
Well,
for it?
okay,
Right?
let's
So,
start
yeah.
with the conventional side. Oh,
Right.
we're dismissed and we get nothing. Or more likely is, oh, you're dismissed and we're going to give you antidepressants. And maybe we're going to give you some little estrogen product that may help your hot flashes. Or God forbid the physician thinks that estrogen is going to cause breast cancer. And they're not going to get anything at all, but they're going to be put on drugs that treat hot flashes. So again, they're being managed symptomatically. That is the traditional conventional side. Or if you get someone a little more involved, they're going to put them on an estradiol patch or an estradiol pill or something, and they might give them progesterone. But nobody on the conventional side even addresses the testosterone piece, which is the most abundant hormone. So on the functional medicine side, however, we're going to, everybody, once they hit perimenopause, needs testosterone replacement, hands down. As they start to move into the estradiol deficiency stage, usually in the 40s, we do what I call support dose estrogen. Because the ovaries are still working, we don't want to replace what Mother Nature was doing. We just kind of want to support it. I call them sprinkling doses. And then we can put in the progesterone typically if they're becoming irregular in periods, or there's sleep or anxiety components or severe PMS. And then when they're in menopause, we're obviously continuing to replace testosterone. Now I'm giving full dose replacement estradiol and still managing with progesterone, and then treating thyroid and everything else that's going on. But I'm going to the root causes versus giving, say, a med to help them sleep, or an antidepressant, or a med to control hot flashes. I mean, when I was 30 years old, I was put on 5 medications to treat symptoms of menopause or perimenopause that I didn't need. I needed hormones. But that's what happens on the conventional side. They get Band-Aids on symptoms without going root cause.
So that age range, that mid-30s, there are a lot of women that are still looking to conceive, right? And so, and I think that for the most part, which is great, right? You know, as long as you're healthy, you do great things. But the thing that I would be concerned about, or they may be concerned about, is like, hey, I want to get pregnant. I have these perimenopause symptoms. I know testosterone is the key, but they told me not to be on testosterone if I'm trying to get pregnant. So how do you strike that balance?
Well, testosterone's challenging because it's what we call category X, meaning that it potentially could cause harm to the fetus. So as clinicians, we can't give patients testosterone who want to get pregnant. If someone is actively trying to get pregnant, I will not give them testosterone. But here's the interesting thing, is testosterone, we used to use it way back before Clomid came out to actually help women get pregnant. Because testosterone, although once you have a fetus in place, it could be potentially tetragenic. But during the process of attempting to get pregnant, testosterone is actually really good for eggs to develop. It helps them mature. And not only one of the reasons our testosterone spikes mid-cycle around ovulation is to help us have that quote-unquote horny feeling to want to have sex, but it also helps the egg, the follicle, mature and actually ovulate properly so that it's a more mature follicle, more apt to get pregnant. So we used to use testosterone like that versus Clomid, where now we are in the Clomid phase. So testosterone is an interesting little molecule. So it spikes for not only the libido issue, but also to help the ovulation and the maturation of the egg that comes out. But we have to be very, very cautious, because if, God forbid, something happens to that pregnancy and we gave them testosterone, we'd be really on the hook for that. So we can't, so I always tell patients, we really need to, we can treat your thyroid, we can do a lot of different things, but I can't treat your testosterone until you've been finished with their reproductive goals.
Great.
Yeah.
So big picture, obviously we talked testosterone, we talked optimizing thyroid, talked about optimizing adrenals. Are there any, in this perimenopause period, are there any diet or lifestyle recommendations that, hey, this is something you should look at doing?
Well, looking at you and looking at what you do, you probably do way better in making those suggestions than I could. But really, I espouse to kind of the low glycemic index eating, Mediterranean diets. High in protein, high in vegetables, and the healthy fats, and eliminating the processed sugars and various things. So a lot of it's very simple. But I know there's all these fancy smancy diets out there. But I think if you stick to the basics and get moving, get some exercise. And I always tell my patients that, and I'm guilty of this myself, I hate to exercise. You put me on a treadmill, my mind is numbed, and I just want to kill myself or put a pen in my eye. But do something that gets you moving that you love. And you and I were talking before this about ballroom dancing. I thought that was so much fun. I got out moving. It was great exercise. So get moving and doing it in a way, or if it's hiking or swimming, or just do the things that get your body moving and increasing your heart rate. But take commonsensical about it. A lot of people are very extreme, I find, when they decide they're going to do something. But extreme doesn't typically last long unless you're a Virgo like yourself. Or some of my other friends. But if you can make modest lifestyle changes, they can go a long way.
Indeed.
And then also supplementing with some IV nutrients, some NAD are really great, or even glutathione. So there's a lot of other really cool things you can do from the functional side that help with mitochondrial health and repair, and even optimizing our metabolic drives. There's a whole host of things.
Right. So it's just supporting a healthy lifestyle.
The common sense things.
Yeah, there's no
But unfortunately now with semaglutide and all these other medications out there, people are getting quick fixes. And what's really frustrating for me is, although I appreciate the weight loss that they're having on a lot of those drugs, a lot of folks are using them as a crutch and they're not making any lifestyle changes. And you could be skinny but really unhealthy inside.
Looking at you, whoever's watching this podcast, using this crutch. Okay, so that being said, you mentioned the difficulty in diagnosis, and we know some of the hormones you want to look at with testosterone, estrogen, progesterone. And again, I understand that a lot of our listeners are not physicians, and they're kind of watching this, and it's like, hey, I want to help my doctor understand this. Right? I want to try my best. I'm going to go there, and I'll be like, hey, slide this little podcast QR code on them. Right?
Yeah, good luck getting them to listen to it.
But from a perspective, if they have a doctor who's going to listen, they can have that conversation, are there any labs that you say, hey, your doctor should definitely take a look at this?
So here's the thing that I always teach even other clinicians when I'm at the Hormonal Health Institute, HHI, say that 5 times fast, is that we have to be careful not to go into tunnel vision. Because as an internist, although I may see different patterns and go, oh yeah, this is definitely hormonal deficiency, but we have to be careful that we don't go down that path and miss other things. So I do think whenever I'm screening patients for hormones, that I also want to make sure I'm doing good due diligence and making sure that, say, their fatigue isn't due to an anemia that's raging, or they have cancer underlying because they're losing a lot of blood in their GI system. So I want to make sure that I'm doing good medicine. So always screening for the basics, making sure the symptoms I'm looking for don't have other explanations. Then when I look at hormones, I always, first and foremost, you got to do a full thyroid panel. And the TSH, T4 that conventional doctors order is not enough. As you and I, we could go into a whole lecture on this, but there's T3, reverse T3, looking at thyroid antibodies that need to be addressed, that deal with all the levels of breakdown that thyroid could have. I also want to check testosterone, a total testosterone level, estradiol, FSH, which is the brain response to the estradiol sitting in the bloodstream. And then I always check a prolactin, which is the breast milk hormone, as a one time, because a lot of women and men in particular have what are called prolactinomas. They're benign, and I'm going to say this again, benign tumors in the brain that aren't going to kill you, but they're going to cause problems with hormones, and you always want to screen for that. So that's a good basic hormone. But then you can get in all the nutritional stuff, the lipids, the hemoglobin A1Cs, looking for celiac, looking for the dairy sensitivity. So there's a whole host of things that you can layer into that, but at the very least get the basics.
Love it. It's awesome. I think we covered a lot of bases here.
My goodness.
A ton of bases here. So I guess the big thing is, the takeaway from this is that, this is, you don't have to suffer in silence. You don't have to suffer at all.
No, not at all.
So.
And that's why I always tell women, advocate for yourself, because a lot of folks aren't going to do it. And if you don't feel right about what you're hearing, and even in my book, I have at the back of it the red flags to look for. If someone says certain things to you, run out, don't even walk out of their office, run out of their office. So, because there are some folks that are going to still be patronistic and demeaning, and they're not there to be your advocates. And unfortunately, we have to advocate for ourselves.
It's unfortunate.
I know, it's really unfortunate, but it's still, as much as I thought it would get better as time has gone on, I've realized 30 years I've been doing this, almost 30 years, aging myself, that it's not gotten much better, which is really sad.
Yeah, and that's the important part. Well, I hope the listeners here are just going to seek that informed, compassionate care, look for it. And if you're not getting that, that's when you start asking questions. There's another direction to go, and just don't accept that. So, and there are resources out there, right? There are a lot of great things on the internet, the interwebs, if you will, but not everything, right? It's just making sure that the source is informed and knows what they're talking about and has experience. And also, speaking of resources, Dr. DeRosa has a website.
Yes.
drhotflash.com. That's drhotflash.com. drhotflash.com. And also, you mentioned your book.
Got a copy.
I got a book. I have a copy of A Woman's Hormonal Health Survival Guide. How to prevent your doctor from slowly killing you. Zoom in on that. How to prevent your doctor from slowly killing you. Not fast, slowly killing you. So, that's a title right there. It makes me want to read it. Wait a minute. I don't want my doctor to slowly kill me.
No, they don't often do it intentionally. Well, most doctors are very altruistic, and unfortunately, the title didn't win a lot of friends with my colleagues. But it was meant to be, obviously, something to catch people's attention. But I honestly believe that most physicians do not want to hurt women.
No.
And they don't want to mess up your hormones, but a lot of us are not trained properly in this. So it's unintended.
Right.
But it was meant to be a catchy title.
But I think we should all get more education in it and just know, hey, and there's a thing, it's like, if I don't know, I got to refer, or to help or guide you to get more information. So that being said, I want to thank you for making time for this today.
It's
this
my
is
pleasure.
Amazing, and thank the listeners for tuning into this here. So if the listeners want to connect with you and learn more about you and your journey, how do they find you? I know we got a Dr. Hotflash.
drhotflash.com. I also, here in Arizona, I have a clinic, DRM, Integrative Health. I've trained some really wonderful nurse practitioners and other colleagues. I've really limited my clinical practice. Now I'm out spending the majority of my time training others, but I have wonderful resources that we can direct you to on the website to folks that do this, or even obviously coming to see people like you, but we can direct people if they just send us an email through that website. So there's not only links for the consumer, there's lots of blogs and information, but also if there's clinicians who want to get trained, there's also a medical provider like there as well.
I appreciate that. That's amazing. And so I think we're good. Here. And so I want to remind everyone out there to embrace this transition from perimenopause to menopause. And I said everyone, my female listeners, embrace this transition from perimenopause to menopause. It is natural, but you do not have to suffer, and you can thrive with this. And that's what this episode was all about. It's been great. We look forward to seeing you again in the next episode of the Dr. Jones Optimization Academy. And we're out.